Hi, everybody. Welcome to our third lecture in the IIH Practitioner Series. So thanks, everyone, for being here. We're going to give it a few minutes and allow the audience to sort of trickle in before we get started. Looks like someone's joined from the World Headache Society, so glad you could be here.
Hi, thank you. Thank you very much. This is Dr. Praveen Thomas from World Headache Society. Thank you. Thanks for having me.
Yeah, great to have you. So my name is Brian Snelling. I'm the here just giving the introductions, and we have a really great talk coming up. Our speaker is Dr. Kyle Fargen. Dr. Fargen is a neurosurgeon, and he's the associate professor of neurosurgery and radiology at Wake Forest University. He's well published in the field of neurosurgery, including idiopathic intracranial hypertension, and he is the author of the book Idiopathic Intracranial Hypertension Explained, a guide for patients and families, and we'll be linking to that book with a link in the chat. So give us a few minutes and we'll get that up. And this discussion will be moderated by Dr. Srikanth Boddu. Dr. Boddu is a neurosurgeon and interventional neuroradiologist at Weill Cornell Medicine. He specializes in venous sinus stenting for pseudotumor, or IIH, and venous pulsatile tinnitus. Gentlemen, thank you both for being here, and I'll turn it over to you.
Thanks for having us. I was asked to talk about Fulminant IIH, and so I'll just start briefly talking about that, and I guess Dr. Boddu, if you want to interject whenever you want.
Sure, yeah.
So Fulminant IIH, the way that we think about that is essentially a rapid progressive form of IIH. The classic definition is progressive and severe visual loss over a period of about a month or shorter. But in general, what that means is severe symptoms, usually with visual impairment, that rapidly, progressively occurs. It doesn't mean that they have to be diagnosed and it occurs within a month of diagnosis. Many of these patients have headaches for a while, but something tips them over the edge and then they have either painful or painless vision loss that deteriorates relatively rapidly. And this patient population is unique to the standard IIH patients that we take care of for a number of reasons, and there's a number of practical points that we have to deal with when addressing them as the treating physician, which is slightly different than the usual slowly progressive chronic headache, chronic papilledema patient. But most importantly is the fact that they are losing their vision rapidly and they could go blind. And what that means is you're talking about evaluating them rapidly, getting them in and taking care of in a rapid manner. And so there's not much published on this. I published a series of 10 patients that we treated with venous sinus stenting for Fulminant IIH about a year ago in the Neuroradiology journal. But essentially, this patient population historically was pretty much universally treated with shunting. And I think now we have enough data and enough experience with venous sinus stenting that many of these patients probably are better candidates for venous sinus stenting if done intelligently. I think it's a really great treatment option. And so why was this something that was managed with shunting before? Well, basically, shunts are a very good way of reducing pressure dramatically and urgently. Although their failure rate long-term is fairly high, they do work well in the short term. They're very effective in the short term. And venous sinus stenting was never really an option until the last 10 years. But those of us who were even aggressive with venous sinus stenting were concerned about this population and putting stents in them, because mainly, what if the stents don't work? What if the intervention that you try to do doesn't reduce the pressure substantially enough? and you've committed them to do antiplatelet agents. And so now you have this patient who you've tried to stent, wasn't effective, and now you have to put a shunt in them while they're on aspirin and Plavix, or stopping those two antiplatelet agents and then doing a shunt with them having a risk of stent thrombosis. And I think rightfully that should give us some anxiety with dealing with these patients. And furthermore, the patients that tend to have visual deterioration that's rapid, what that means is that their pressures are probably quite high. And most of these people on spinal taps have pressures that are in the 30s or 40s, sometimes higher. And sort of by definition, pathophysiologically, to have a pressure that high on a spinal tap mandates that they have a pretty large pressure gradient that's accumulated across a venous sinus stenosis. In general, patients in this group have gradients in like the high 20s range. In my series, I think the mean gradient across the transverse sinus was like 28 or 30. So we're talking about these patients with very severe stenosis, with very large pressure gradients. And so they're really ideal candidates for stenting. But one of the main problems that we face with this patient population, because they are progressing rapidly, we want to temporize them by removing fluid. And so usually that means that, you know, they show up and we're really concerned about their papilledema. We would want to do a spinal tap. We'd want to measure their opening pressure, and we want to drain them down. Draining them down reduces their intracranial pressure. It gives their papilledema a little bit of a rest, and hopefully it keeps them from progressing, at least in the short term. Well, the problem with doing that is that if you do a spinal tap and you drain them down, you remove you basically lower the intracranial pressure, and then you take the extramural compression away from the sinus. So if you are familiar with this positive feedback loop hypothesis that we have regarding why that transverse sinus stenosis develops anyways, we think it's occurring because the intracranial pressure is high. There's the brain and the fluid around the brain. That compartment and the pressure in that compartment is high. And there's an area of sinus, usually the lateral transverse sinus, where it is susceptible to extramural compression. So this high pressure is basically pushing on the sinus where it's exposed, which causes the vein to narrow, which causes less blood to travel through. So you get venous congestion upstream. And because fluid reabsorption is dependent on vein pressure, if that vein pressure is higher, it naturally makes the fluid pressure higher, which then causes more pressure within that compartment and then more pressure on the vein. And this process repeats itself, we think, until eventually the vein is very narrowed. And patients are locked in this situation where they have severe transverse sinus narrowing, very high venous upstream pressures, and then very high intracranial pressures. And we think this is true because if you then take that patient and you do a spinal tap on them, or you put a lumbar drain in them, or you put a shunt in them, anything that reduces the pressure of that intradural compartment, you will reduce the pressure on the vein, and therefore you will remove the extramural compression from the sinus. So let's say you have this patient who comes in the emergency room and
Dr. Fargen?
Yeah.
I interrupt. It's a very interesting question. It is the couple of things. It is the first of all, the Fulminant IIH is a very scary concept from the patient perspective. How would you, are there any things for them to identify? Like most of these IIH patients, they are suffering for at least 2 years before they find the right physician. But unfortunately, the patients with the Fulminant IIH, they don't have that luxury. is there any features you can tell the patients from your perspective they need to watch for and rush for the medical care?
I think in patients that have not been diagnosed before, it's kind of hard, because if you don't know you have this problem, maybe
Yeah.
you've had migraine, or what you've been told you have migraine headaches your whole life. I think it's hard to wake up one morning and not be able to see and to understand what's happening, or to realize that your peripheral vision is missing when before it was okay. I think that's going to be a hard thing for somebody who doesn't have the knowledge about what's going on to immediately recognize that as IIH. However, theoretically, they should recognize the fact that they can't see, and hopefully they'll go to the emergency room. The good thing is these patients tend to have relatively severe papilledema, so even a novice who looks in the eye should probably be able to tell it, and we'll get and because papilledema is really only seen with high pressure in the head, and most ER doctors or ophthalmologists or whoever, the optometrists even, they are familiar with papilledema and know that it means ER, and so many people end up there. I think
that is a great one. It is most of these patients, they end up either in the emergency room. Nobody's saying as an IIH, they are coming in as a sudden deterioration of the vision. And almost always by the time we get called in, the ophthalmologist saw the patient. He said, oh, this is a grade 3, or not even grade 3. It is usually grade 4 papilledema they are calling us as. So it's mainly the presenting is rapid worsening of the vision in a week or within a couple of days. That is what is bringing them to us.
With that being said, classic fulminant IIH is within a month. I would say that a lot of the patients that I've taken care of that have severe progressive visual decline, it occurs over like a 4 to 6 week time period. And most patients with IIH, I would hope, have been told at some point that their vision's at risk, and that's something that can happen. But many of the people that we end up seeing they have headaches. They've had headaches for a long time. They have a known diagnosis. They see an eye doctor, and then they notice over a period of a few weeks that their vision is acutely getting worse. And most of those patients, if that were you, they recognize that there's a problem, and I think they know to do something about it, because people have told them they're seeing an eye doctor. They have been for months and months, and they kind of know that that's what to look out for. So I think thankfully most people don't show up blind, but they show up in some time period where their vision is salvageable, which I think is really important.
Yes, just as another question to continue this point, and I have a couple of questions in terms of the from the audience in terms of CSF measurements and things, but to continue on papilledema. Can they have patients with a fulminant IIH? Can they have like a worse papilledema, grade 4 in one eye, and a minimal papilledema, grade 1 or grade 2 in the other eye?
I would say the answer to that is I think it's common for them to have different grades, but it's not that common to have severe, like 5 and a 1. Usually it's like 3 and 4 or something like that. And so because of the global effect of the pressure, there's usually a fair amount of symmetry there, but often asymmetric to some degree just because of anatomical variability.
Sure, and have you noticed that variation more pronounced in patients with transverse sinus, being a both sides symmetrical dominance versus one side dominant and the other side is hypoplastic or aplastic?
Yeah, I have not noticed any relationship to dominance. What I'll tell you, just I was talking about the narrowing and the process which that happened, and the point I was going to make, and then I'll hit on the dominance here for a second, is that if you do a spinal tap on somebody and you drain them down in the ER because you're worried about their papilledema, you assume that their vision's really bad, their papilledema is really bad, and you're like, well, we should get an opening pressure, and you measure that opening pressure, and then you say, well, let's drain them down to alleviate their symptoms or to give them a period of time of relief. When you drain them down, you will reduce the venous sinus stenosis that you will see, which means that you potentially jeopardize any further imaging that you get. If it's an MRI or an MRV or an angiogram where you go in and measure pressures, you jeopardize the gradient by doing that up front. And we'll probably hit on that again later. So in regards to the dominance, if you look at all comers for sort of all patients, the majority of patients are right transverse sinus dominant. That's about 40%. And that's where the superior sagittal sinus continues as the right transverse sinus. And the right transverse sinus is larger than the left. About 30% of patients are codominant, where still the superior sagittal sinus continues as the right transverse sinus. The left side predominantly continues from the straight sinus. However, those two pathways are both equally sizable. So there is an anatomical difference between the right and the left pathway, but they're about equal. And then about 30% of patients are the reverse of the right, where their left transverse sinus is the continuation of the superior sagittal sinus and is clearly dominant. For patients to get to have a high pressure gradient, it essentially mandates that both transverse sinuses are narrowed. Unless one pathway is remarkably more dominant than the other, or it's much larger, or it's aplastic or hypoplastic, but almost always, even when one is dominant and the other one is visible, they're both narrowed, and they're both usually narrowed at the lateral transverse sinus. I have a whole theory as to why that develops. I don't really want to get into it as to why that specific location, but it's the most susceptible site, I think, for extramural compression. And usually it's mirror image, even if one side's big. Now, with patients that get fulminant IIH, where they have astronomically elevated venous pressures, I have seen a fair number of them that have concomitant caudal superior sagittal sinus stenosis, meaning that they have lateral transverse sinus narrowing. Then they have an area sort of in the medial transverse sinus, which looks relatively spared, the torcula, which looks relatively spared, and then the caudal superior sagittal sinus is really tight with a secondary gradient there. And oftentimes, in normal IIH patients that aren't fulminant, it's a very common place to get a second stenosis, and you might see a 2 or 3 point pressure gradient there. But sometimes with these patients, you're talking about an 8, 10 point gradient at a second location in the superior sagittal sinus. And so you have to be mindful of that as well, because you would potentially need to stent both of those to adequately reduce the pressure. A lot of people are not comfortable stenting the superior sagittal sinus. It is not a routine thing most people do. In my practice, I do it all the time. Like, I am very aggressive about stenting the superior sagittal sinus with the transverse sinus, and it's very safe. And I think it is beneficial in a lot of situations to prevent upstream stenosis that develops there, or a worsening gradient that would develop once you treat the transverse sinus.
So you do the manometry extensively before considering stenting.
Yeah,
correct?
yeah. So here's how I look at it. So I'm a neurosurgeon. You're a neurosurgeon. So we have stenting, and then we have shunting. And my general, the way that I think about this problem is, shunting is suboptimal for the patient, I think, as a long-term treatment when you can stent, but it's the standard sort of safe way to go. And what I try to do in my general practice is exhaust endovascular management, leaving shunting for the end, for this group of patients that fail other therapies or where we can't stent. But the problem, I think, in fulminant IIH is you have to be sure that the treatment you're going to offer will lower their pressure sufficiently to make their vision better. Because if you
Okay.
stent them,
Here is-
yeah, if you stent them and then you put them, you subject them to dual antiplatelets,
Yeah.
you better be certain that that's going to work, because if you got to shunt them and they're on aspirin and Plavix, that's a big problem.
Yes, I'm a big believer of the endovascular treatment of the for this IIH. But now it is on this topic, I want to just have a couple of questions. So you are saying we want to make sure the endovascular treatment is optimal to reduce the pressure immediately because of the dual antiplatelet risk and things. So my question is, how soon after the stenting you notice a drop in the gradient? Will you measure the gradient right away after the stenting on the table or not?
So that's a good question. So let me tell you my general practice. I'll hit on this. So my general practice, I have a patient that I see in the ER, can't see. MRI suggests, we think it's pseudotumor. I'm highly suspicious of stenosis of the transverse sinus. If we haven't done an LP yet, my usual management strategy is to do an awake venogram. Meaning that, so I go in the leg, that's usually my approach. I tend to do an arteriogram as well. So I do an arteriogram, I look at the venous phase imaging, I look at the outflow, I look for narrowing. I then I go up and I measure pressures while they're awake. This is in the acute setting. Like I will from the ER, just do it in that situation. And I'll basically look for superior sagittal sinus and transverse sinus stenosis that's amenable to stenting. And we get a gradient. We understand what their baseline is when they're awake, while they're high pressure. Then on the table, I do an LP. So I turn them on, I put a closure device and I turn them on their side. I bring the X-ray machines in. I do a spinal tap. I measure their pressure and I drain them down. Some groups had put lumbar drains in. I don't think that's necessary. I don't think you need to do it. So I don't advise doing that. But that way you confirm their pressure is high and you drain them down and you temporize them. So if you take them from 45 to 10, you will give them some respite from the high pressure. And then usually what I do when I've confirmed on that study that the gradient is sufficient, and I have a slightly higher threshold when I'm setting somebody with fulminant, obviously, because I want them to do well and I want it to work, but we talk about that later. But then what I'll usually do is when I'm convinced that I think stenting is the right option in that situation is I'll give them a dual antiplatelet load. I put them on aspirin Plavix. Orally the day before, I'll usually stent them the next day under general anesthesia. And so that way they've had an LP. We've got all the information we need to know about whether they're a candidate for a stent and how big their gradient is. We've drained fluid off. Now we give them dual antiplatelets. We don't have to worry about doing an LP on aspirin Plavix. We load them on it afterwards. Then, and after we've established our blueprint of where we're stenting, what gradients there are, now it doesn't matter if you drain them down. If you get rid of that extramural stenosis temporarily, that doesn't matter anymore because we know what we're stenting already based on the venogram we did that was awake. So usually the next day, I put them to sleep under general anesthesia. I measure baseline pressures again. It's always wise to do that. Understand your baseline before you intervene while they're asleep. And then I stent. And my usual practice is to stent the entire transverse sinus from torcula all the way to sort of the transverse sigmoid junction. If there's any superior sagittal sinus stenosis with any sort of gradient, my usual practice, which is aggressive, I understand that, but it's to stent the superior sagittal sinus caudally as well, and then through the transverse sigmoid junction. And then after I've done that, I go up and I remeasure pressures while they're asleep. If they've developed any sort of de novo stenosis upstream of the stent, I'll stent them while they're asleep and then remeasure again when they're after we've done that until that gradient has gone. Usually then I wake them up and I don't remeasure while they're awake. I don't repeat a venogram the next day unless I have a really good reason to. Most of these patients, they awake from anesthesia. If they had tinnitus in the ear, it is gone. Obviously have a bad headache. Their vision usually improves by the next morning. So most people, when you stent them acutely and they have bad vision, by the next morning, they will tell you, I can see things better. The room is brighter. My vision is better. It's not perfect, but it's better, which is quite helpful. If the tinnitus is gone, that tells you that the transverse sinus stenosis is well treated. And if the vision is subjectively better the next morning, then I don't think there's a need for any sort of further evaluation. I don't think you have to like get a CTV. I don't think you have to repeat a venogram to confirm that when they're awake. And because they're on aspirin and Plavix, I don't think you need a spinal tap to confirm that. The papilledema, usually, I'm not an ophthalmologist, but the papilledema usually a week later is improved. And so you have them, well, you have them follow up in a week to see their eye doctor again, get checked. Almost always it's better. And then at 2 weeks or 6 weeks, it usually continues to get better. And then if that's the case, you're good.
So you are saying it
the
is
right option.
you are saying by the end of the stenting, when you measure the pressures again, the gradient is practically gone. So the pressures are back to it's a uniform pressures. That's correct.
Yeah, that's how. So in general, and not just Fulminant, but in any situation, I think it's very important to measure superior sagittal sinus, kind of S1, S2 segments, all the way down to the sigmoid sinus before stenting, to understand how anesthesia has affected your gradients compared to when they were awake. Some people just do this all asleep. That's not my usual practice. But confirm while they're asleep, pre-stenting, what those pressures are. And then after stenting, going back up. And the important thing, in my view, is to go all the way up in the superior sagittal sinus, because the most common place people get immediate restenosis is either right upstream of a transverse sinus stent. If you only put if you only stent the lateral transverse sinus, the medial part is high risk for basically narrowing immediately, or the superior sagittal sinus. And so remeasure those to confirm that the gradients are gone and there's not this big buildup of pressure. And that makes you feel a lot better when you conclude the procedure, knowing that you've reduced the pressures as you want them to. And that's a surrogate for ICP.
Yes,
So
that is pretty
that venous pressure measurement.
effective immediately. Yeah. So knowing that is pretty effective immediately, what is your common stent sizes you use in these patients?
Yeah, so for me, I use precise stents. Those are, to be honest with you, it's just, I'm used to using them. I use them all the time. It's a pricing thing as well, an availability thing. So that's what I've been using for years now. So the stents that I use, they're all 40 for the most part, 40 or 30 in length. To cover from the torcula to the transverse sigmoid junction is usually 70 millimeters. And so it depends on the size of the sinus. I've been personally measuring on AP and lateral just venogram images. That is not ideal. The best thing to do would be to actually measure the circumference because it's triangular shaped on a CTV. But I have found that in general, you can measure the diameter on like an AP or a lateral venogram, and then use a stent size that's roughly maybe a little bit smaller than that maximal measurement. And for most patients, it's 6 millimeters in the transverse sinus, meaning towards the torcula. Some just have giant ones, and the giant dominant sinus, I'll use an 8. And then usually as you get towards the transverse sigmoid junction and then the sigmoid sinus, the diameter increases. So usually I use like a 6 by 40 in the transverse sinus, and then maybe an 8 by 30 or a 7 by 30 in the transverse sigmoid junction. And then for superior sagittal sinus, if you do decide to stent there, I usually go small, usually 5x40 is the preferred thing. I don't think you usually need anything bigger than that. There's actually a risk of
basically
stretching the sinus.
So we need
There's usually a risk of stretching the adjacent. If you go too big, if you oversize, mechanically, I think you can stretch the sinus next to it and actually induce stenosis by stretching it. So I would refrain from going too big.
Yeah. So basically, when you are stenting this, you need a stent that gradually increases in size. And in your case, we have to do an overlapping stent. So you are using a 6 in the transverse sinus and probably 7 or 8 in the sigmoid sinus. That is correct?
Usually, yeah. And they telescope each other a little bit. So, and that's not ideal. I mean, if you have a biliary stent that's 70 millimeters, and you find a size that's appropriate for the transverse and the sigmoid, that's totally fine and totally reasonable. I don't want you to think that you should use precise stents just because I do. But that's just my practice. I've been doing it for years now, and I've gotten really good at it. And it just, and I haven't any complications. So that's why I use that.
Yeah, I mean, that is a great point in terms of these sinuses, how they change in caliber as they are increasing from superior sagittal sinus all the way to sigmoid sinus, 5, 6, up to the 8. So, I mean, yes, from the point what you said, we can use the biliary stents, one stent from 7 or 8 going to 80 millimeter long. But unfortunately, if we can have a stent that can increase or vary in size, like approximately 7 or 6, by the time it goes to distal, it is more 8. That would be a great one. But that is something it should come out.
Well, I'll just say, like, not being affiliated with Serenity, the River Stent does that, and I participated and I put a number of those in, and that's one nice thing about it is it basically does that.
Oh, great! It is.
So I do think with the current technology, I find myself very commonly upsizing laterally because it's always bigger near the sigmoid sinus. So
and one more, just for my curiosity.
Yeah. Go ahead, I'm sorry, go ahead.
I mean, it's yes, venous stent practice. It is. How do you feel when you are? I guess your follow-up is with the MRVs, correct?
So, yeah, my practice, I don't like subjecting patients to unnecessary tests. So what I tend to do is if I stent them and their vision improves, their headache is better, their pulse oxygenation is better, they're doing well, I will have them get eye exams, especially for Fulminant. They need to have their vision checked and their papilledema checked. But if they're doing well, I don't get repeat imaging. I see them at 2 weeks and 6 weeks. And the main reason being that I don't, precise stents particularly do not do well with MRI scans. If you get an MRV with a precise stent in, it'll look like the veins occluded because of the artifact from the stent. And so I don't want to subject patients to unnecessary radiation or contrast eye if they don't need it. And so my usual follow-up plan for patients who are doing well is absolutely nothing. I see them back, and if their vision is better and they're doing well, we start to wean Diamox potentially, and then they just come back if they need something. If
that patients, is so true.
I'm sorry.
That is so true. It is this is one of the common questions I get from the outside physicians. Saying whenever you do an MRV as a follow-up for these patients at a 1 year to make sure everything, because when we need to taper down the dual antiplatelets and things, if the scan is done outside the institute, almost always you get the read saying, oh, the sinus is thrombosed or occluded. that is one of the unfortunate limitations of the current stents we are having, given the more metal density or these things, it is causing more susceptibility on the MRI, and that limits our evaluation. This is even with given contrast.
I completely agree.
So that is,
I'm glad to hear that you have the same experience I do with MRI scans. So the way I've gotten around this, or as much as possible, is I tell the patients when we stent them, the stents are MRI compatible. They're not going to go off in metal detectors, like they're not going to migrate. I tell them all that. And then I tell them, however, if there's a problem in the future, if you go to some hospital or somebody does an MRI, tell whoever is getting that scan that it's going to look like you're not going to be able to see the sinus inside the stents, and it might look like it's occluded. And so if they're getting that scan specifically because you have a headache and they're worried about the stents, a CTV is the much better study. And if you tell all the patients that and you inform them about that ahead of time, that will mitigate some of this problem, because they'll tell the physician that, and then they'll order a CTV instead, and then you won't have to worry about. But I've gotten plenty of phone calls from patients freaking out saying my stents are occluded.
Exactly.
And like it's just a consequence of the imaging that they usually order for this problem, and not understanding that issue with the stents.
Sure. So if we have to go back to the quick, can you, for the our audience, from an audience perspective, in layman terms, can you tell the difference between the shunting versus stenting? That's one of the concerns of the audience, please. More in the layman terms, please.
Yeah. Well, so stenting is, as we talked about, it's putting metal into the veins in the head to hold the veins open where the vein was narrowed, to reinforce the vein so it doesn't get narrowed anymore. And with the main purpose, the stent reduces the vein pressure in the head, which then allows the fluid to get reabsorbed at a lower pressure. It reduces the fluid pressure in the head by reducing the vein pressure in the head. Stenting is great for a number of reasons. Mainly, it's minimally invasive, and but also it's actually addressing the fundamental problem of IIH, which is that the vein pressure in the head is too high, which is making the fluid pressure too high. It's repairing a bottleneck to allow the vein blood to get out of the head, therefore keeping it from building up, and therefore preventing the fluid pressure from building up. A shunt is a surgery that we do in the operating room, where we drill a hole in the top of the head, we pass a catheter or a small tube through the brain into the fluid chamber of the brain, and then that catheter comes out of the head and gets tunneled down into the belly, and it reroutes fluid out of the brain into the abdomen, and or some other place. Shunting is like a constant spinal tap. It drips fluid constantly out of the head to lower the pressure in the head. And it's an immediate way of reducing that pressure. The problem with shunting is that first off, it's a brain surgery. We're putting something into the brain, into the belly. But shunts have a tendency to fail. They have a very high failure rate over time. And that failure happens for basically one of two main reasons. Either the shunt gets blocked, meaning the catheter that's in the brain or the valve that regulates the flow through it, or the catheter in the belly, it gets blocked. So some blood clot or material gets into it, or it gets, stuck in the belly and trapped in some space, and fluid can't drain through it, in which case the shunt completely fails. The pressure just builds back up again, and you're back in the same situation. Or more commonly, the fluid chambers in the brain collapse around the catheter in the brain. And when that happens, the shunt drains that one fluid chamber really well, but no longer drains the rest of the fluid in the other chambers of the fluid around the brain. And so basically when that happens, it takes about 8 weeks. It's almost universally happens in most people. When that happens, not as much fluid is still draining through the shunt, and the pressure will now increase. So patients oftentimes, if their pressure was 35 before the shunt, you put the shunt in, and immediately their pressure is 15, they feel great. And then about 3 months later, their pressure is hovering in the low 20s, 22, 23, 24. And you get a CT scan, people feel bad, and the ventricles are collapsed around the catheter. And now you've reached a situation where that shunt is doing all that it can, but because the ventricles have collapsed, you're not draining as much fluid as you were before, and the fluid that's around the brain isn't communicating with the fluid of the ventricle anymore. And so the pressure is at a point, it's not as high as it was beforehand, but it's at some point where people aren't happy. They're still having pressure headaches. The good thing is, usually even with a shunt in that's partially working like that, most of those patients aren't losing vision, because it's maintaining them at a pressure that's usually below papilledema range, kind of in the low to mid 20s. It's not still in the 30s or 40s with a shunt. But shunts are a real issue. They have to be fixed very frequently. And because of that, and they can get infected and people can have seizures and all this other stuff can happen. Because of that, in my view, as I mentioned before, I think really stenting is the first line treatment when it's safe, when people are a good candidate. And we can reserve shunting for people that either fail stenting or that aren't a candidate and there's nothing else we have to offer them. And then shunting is a good option in that population. But upfront, most people, particularly with vision loss, are better treated with stenting. I hope that answers the question. I don't know if that was
it's
what they're
quite
looking
deep.
for. But
One more, it is the so yes, it is understandably there is concerns of transferring from a stenting to shunting because patient will be already on dual antiplatelets. But at what point, in terms of the timeline wise, at what point you are going to declare stenting is not working, patients should have a stent, especially in patients with fulminant IIH?
So that's a great question. I've taken care, I think I'm up to about 15 patients at this point that have had what I would define as a fulminant rapidly progressive IH picture. And I've stented all of them. And only one of them wasn't better 2 days later. So all of them did very well, except for I had one patient that had lateral transverse sinus stenosis with a massive, like 45-point gradient. Superior sagittal sinus was totally fine. Lateral transverse sinus was crushed, big pressure gradient. I stented her transverse sinus. Everything went perfect. The pressures came down like they were supposed to. And we discharged her the next day. And she called 3 days later saying, I'm not any better. And in fact, I think my vision might be worse. And she was the one outlier. Everybody else did very well, and their vision just was better the next day, and they were fine. That one patient, because she's on dual antiplatelet agents, and I didn't want to do a spinal tap, I didn't want to do a shunt, because she felt significantly worse, we got a CTV, and there was severe superior sagittal sinus narrowing that had developed. So I did a repeat venogram. This is like 4 days after her procedure. I went back in, and she had her superior sagittal sinus was just crushed, and she had a 50-point gradient that had developed that was not there before. There was no narrowing there before that developed in the superior sagittal sinus. And so I re-stented her 5 days after her initial stent procedure. I put 2 stents in the superior sagittal sinus to make sure I had covered adequately far enough rostrally. And she did wonderful. The next morning, her vision was better. Her headaches were better. She had stent pain, but the clear pressure symptoms were better. And actually, she's done great. And that just goes to show you, one, how weird this problem is, and how strange the stenosis is, and how the stenosis that develops is not a focal thing. don't think that this is just the lateral transverse sinus. The entire dural sinus tree is compressed to some degree by the high pressure. But so keep that in mind. There's always the opportunity for narrowing to develop somewhere else. But in a situation like that, where she very clearly was worse, when you would expect her to be a lot better, something had to have happened. And of course we found it, and then we could treat it with stenting. And so even she didn't need a shunt. So out of all the 15 patients I've taken care of, all of them, even including her after her repeat stenting, did very well. Nobody needed a spinal tap during that 6-week time period where I keep them on dual antiplatelets. 2 patients 6 months later developed recurrence of symptoms, one of which I had to shunt. Her situation was quite interesting from the standpoint that her venous pressures were very high when I first met her. She had a huge pressure gradient. And I stented her, and her pressures dropped just like you would expect. And then at 6 months later, she had recurrence of her papilledema. And her spinal tap pressure was again in the high to mid 30s. I did a repeat venogram on her at that time to assess for some new stenosis that had developed. And very interestingly, she not only did she not have any venous sinus stenosis, her venous pressures were basically normal. So she had developed this weird thing where her opening pressure and her vein pressures, which were coupled together initially, when I saw her back, they had decoupled. Just her fluid pressure was just high, and she didn't have an elevation in vein pressure. So because she had progressively worsening vision, she got a shunt. That does not happen very often. But that was the one patient out of the 15 that I retreated with shunting. Everybody else has not required one. What I will say, there's a unique subset of, let me just, sorry. There is a subset of patients that develop fulminant IIH in the setting of venous sinus thrombosis. And those patients, they get basically rapidly progressive vision, papilledema and vision loss, but they've thrombosed their outflow pathway. Blood's trying to get out of the head, whichever route it can. And some of those patients, depending on whether they get placed on heparin and they get some recanalization of their sinus, some of them might potentially be candidates for stenting too. In my practice, those patients, I have not had the courage to stent any of them. And I've been shunning those people. In a delayed manner, if their shunt stops working and there's a problem, some of them are potentially amenable to stenting after it recanalizes, and there's some element of stenosis that has developed following recanalization. But in those patients with thrombosis, I've just been going right to shunting because I think probably it's the better, safer option. I don't know if maybe that's on a side, but I just figured I would mention it.
Dr. Fargen, could I jump in with a question? So
Yeah.
there's some neuro-interventionalists on the call. For yourself and Dr. Boddu are pretty far down the field of like the number of cases you've done and your experience. So for those who maybe are coming out of training or didn't get much venous sinus stenting in training, where does fulminant IIH fall into would you say, look, you need to do so many cases that aren't fulminant IIH before you tackle a fulminant IIH case? Because like you said, you really can't go back once you commit them to dual antiplatelets. That's
a good question. The treatment is the same. I think the risk of the procedure is the same from the standpoint, technically speaking. I still think it's very low risk and very safe to do. It's a decision-making standpoint, right? And so if you're going to do it, you should probably be confident in what you're doing and the decisions you're making. I think that's important. So if you don't have much confidence in dealing with this in the first place, then this is not the patient to learn on or try on.
Right.
But I think what it comes down to is being smart about it. And when it comes to stenting somebody who has pulsatile tinnitus or, papilledema and they have transverse sinus stenosis, I will oftentimes stent people with gradients that don't make it to 8, especially connective tissue disorder patients. I see a lot of them. I have this weird practice where I take care of a whole bunch of people with connective tissue disorders from the East Coast. And some of them I'll stent for gradients of 4 because they're so sensitive to the vein pressure and to the fluid pressure. But in most normal IIH patients, 5 or 6 for me is a reasonable gradient to stent. With Fulminant IIH, it really should be higher than that. You want to be sure that what you're doing is going to lower the vein pressure significantly, which will then result in a drop in the fluid pressure that's significant for that person. So I would think a gradient threshold of 10 or 12 would be more reasonable. Most of them, I'll tell you, if they're losing their vision, it's usually in the high 20s. And so it's not really a question about meeting that threshold. But I think if you're not confident with what you're doing, that's probably not the patient to try it on. But these patients are also sometimes the best patients to treat with stenting. Like I find these patients are really good candidates. In general, if you're talking about like somebody who's a good candidate for a stent in IIH, you're talking about somebody with painless vision loss. Best candidate. Because they have high pressures, they're losing their vision, and they need something done, but they don't have headaches. These are the patients, you stent them, they're good. Like it takes care of the underlying problem. Their vision gets better because they're not having headaches. They don't have headaches recur because they didn't have them to begin with. And so they do really well. So somebody with fulminant vision loss, because they have a huge gradient and high pressures, they're probably also going to do really well with stenting. And so if you're not comfortable dealing with it, to some degree, I think it's not the best thing to send them to a neurosurgeon to put a shunt in, because that isn't probably their best option. At the same time, these are not good people to learn on. Sure. And so if you have somebody like that and it makes you nervous, send them to somebody who is in the area that can and will confidently stent them, I think.
Got it. Thank you.
That's my take on it.
Fulminant IIH makes up to only 3 to 4% of the entire IIH incidence. So by the time you encounter a patient with an IIH, you statistically would have treated at least 30 IIH patients by the time you come to that a fulminant IIH patient. And that's right. It is Dr. Fargen said, it is the that is the same in my experience as well. I am yet to see a patient whom we decide, oh, this is a stent is failed, I need to shunt this patient on an emergency basis. No, I haven't. In the last 12 years, we haven't seen that one. So still it is a stent remains a very good option for these patients, being a minimally invasive. And dual antiplatelets, personally, I keep my patients on dual antiplatelets for 1 month. I know some practices keep them for 3 months, and then they go down to the aspirin and even down to the baby aspirin. So it should not be an issue at that point for taking the patients for shunting if needed.
Yeah, and the one time, as I mentioned, that where I had somebody that was getting worse, it was restenosis, and they were amenable to stenting. So I completely agree.
Great. Just a couple more questions here. I know we're running short on time.
Yeah.
One last question.
Yeah, the question. Sorry.
Go ahead, Dr. Boddu.
Saying it is the one of from audience is, are there any anatomic abnormalities in the sinus wall that account for the stenosis occurring in certain locations?
There's a lot of weird things that are happening in the sinus. There's studies that have anatomically done cadaver studies looking at the sinus, and there's webs and there's weird. There's some weird sometimes dual channels and stuff like that, but for the most part, arachnoid granulations account for the majority of the intramural stenosis. These are these like little balls of arachnoid that oftentimes we'll see. In my practice, I haven't seen giant gradients across arachnoid granulations. Almost always when somebody has a really big pressure gradient, it's across an extramural stenosis, meaning compression from the outside. And that's unrelated, I think, to the wall of the internal lumen of the vessel. Arachnoid granulations do cause stenosis and can cause gradients and can be treated very easily the same way. But usually they don't cause these giant gradients like we see with fulminant, at least in my experience. As far as I know, the reason that some patient who gets transverse sinus stenosis and develops this problem, and their exact doppelganger who like looks the same height, same body mass, same age, same gender, doesn't develop it, I think has to do with some sort of weird inherent susceptibility of that patient to getting extramural compression of the sinus. In connective tissue disorders patients, maybe it makes more sense because, well, they have a connective tissue disorder, their vessel wall may not be the same, not have the same integrity. But in the standard patient, I think fundamentally it has something to do with the vein being exposed to compression at that site more so than it should be. And that's probably the fundamental driver of their problem. That has not been confirmed with anatomical or cadaveric studies. That's just my hypothesis, if that's helpful.
Great. Well, I know there may be a couple of questions left in the chat. We're probably gonna try to answer those. We'll get back to the individual people via email. I want to be respectful of Dr. Fargen and Dr. Boddu's time.
I have some more time if that's okay. I can talk for a little bit longer. If you want to kick me off, that's okay. I understand, but I have like 10 minutes if there's more questions. I don't mind.
Let's see. I think we may have. There was one question about and this may be a preference question regarding lumboperitoneal versus ventriculoperitoneal shunts.
Yeah.
What are your thoughts about that? I know neurosurgeons.
So that's a discussion right there. Briefly, ventriculoperitoneal shunts, I think are easier to place. It's the valve setting. These shunts have valves on them. They sit on the skull. They're much easier to reprogram. Ventriculoperitoneal shunts tend to work longer, meaning the shunt stays patent, the tubing stays patent for longer, in my experience. The problem with them is the ventricular collapse. When the ventricles collapse, it doesn't drain as much fluid. It doesn't drain fluid freely communicating between the ventricles anymore. That ventricle almost gets trapped. And so, and therefore the pressures tend to go up slightly and patients oftentimes feel bad. A way to get around that is to put a second shunt in on the other side, which some patients need. But trying to revise the shunt where you take out the catheter and swing it over to the other ventricle, the same process just happens over 8 weeks. It's like a recurring issue. It's a big ordeal that we face with these. And if you try to revise them, you try to take the catheter out and just put another one in, it's the same problem you run into repeatedly. Lumboperitoneal shunts don't have that same problem. The catheter goes in the back, it sits in the thoracic or the lumbar cistern where there's this big fluid space, and patients are upright, so the fluid just pools in the back, and so you don't have this problem with collapse around the catheter. So they tend to drain very effectively, and they can drain to really low pressures. You can overdrain patients very easily with a lumboperitoneal shunt. The problem with lumboperitoneal shunts, there's multiple. Number one, the catheter that goes into the spinal canal, because it has to go through a 2E needle into the spinal canal, is small. It's a small caliber. And I think they get occluded faster with protein and other junk because of that. So the catheter actually gets blocked faster because of that. Also, there's this whole component of the fact that the fluid that's in the brain is not necessarily equivalent to the fluid that's in the back. Protein, cells, things that are heavy settle by gravity. So the viscosity of the fluid in the spine is probably slightly different. It's probably more viscous. There's more junk in it, which I think adds to the fact that the catheter in the spine gets occluded more readily. The valve sits on the side in soft tissue. And because of that, it can move around and it can rotate. And if people are thick and big, it can be hard to reprogram. As you push the reprogrammer down on it, it just pushes away. Unlike the skull where you can set it down and it's a rigid structure. And some of these people, like, you can't reprogram their shunts. You try and you can't. I've sort of gotten around this to some degree by putting a plate. We have these like plates for craniotomies. And if you put a plate behind the valve and kind of tie the valve to it, it keeps it from shifting. You suture the plate down in the fat and it keeps it from moving, so you can get a better sort of foundation to reprogram on it. But oftentimes you can't do it sometimes, and they're locked in whatever position. You have to take them back to the OR just to reprogram them, which is a pain in the butt. Also, because they're harder to reprogram, you can't use some of the finer controlled shunt valves. So usually you have to use one with a magnet, like a Certus valve, which has less settings available. And then finally, the catheter that goes from the side where the valve is placed into the belly, because it's a short distance, oftentimes they back out. When people strain, it's a shorter distance. And so the catheter will slowly like come out of the belly and coil up on the side. And so it's much more common for these to come out of the belly into the side pocket and then fail because of that. So I all of that taken together, I don't like LP shunts very much. I went through a phase where I was putting in a bunch of VP shunts and I was dealing with the ventricular collapse. And we'll put in LP shunts, and then I was revising them so often because they kept failing. I've sort of switched back to being a VP shunt, brain to belly preference, neurosurgeon. I don't know if maybe that'll change again in a year or two. I don't know. I don't like shunts in general, but some people need them. And I found personally that I think VP shunts are just easier to deal with and handle, and they tend to work longer. So
Yeah, I agree. I think
that's my take on it.
For the various other reasons we put VP shunts on our patients, they tend to work well. So I think there's also just some more familiarity there.
But just keep in mind that it's very likely if you put a VP shunt in, patients will feel great for 3 months. They'll say, "Oh, I feel wonderful," and they'll come back at 3 months or 4 months and they say, "I got headaches again and I don't feel well." If you do a spinal tap on them, the pressure was going to be higher than the valve. Whatever the valve is set to, which should be potentially what the pressure is in the head, the pressure will be higher than the valve setting. And what's happened is the resistance in that system is no longer controlled by the valve. So you can turn the valve all the way down to nothing, and it's not going to make their pressure any lower. The valve, the resistance in that system is at the interface of the catheter and the ventricle. And so you turn that thing all the way down, it's not going to change. They're still going to have headaches. Their pressure is still too high. Their pressure is probably in the low 20s. There's not a way around that unless you want to try to revise it. And that's not going to particularly work very well. So that's something that a lot of people don't understand. I just know this because I put in a lot of shunts. I do a lot of spinal taps on people after I put shunts in them. And it's amazing how their opening pressure is very clearly highly dissociated from the valve setting, to where the valve setting like doesn't really matter anymore.
So I know you said you've got a few minutes left. So that's one good question. What part of your practice is patients that have been shunted for IIH? And then do you find that there's any like group of patients that have sort of failed shunting, or have that suboptimal shunting outcome that could benefit from stenting?
Yeah. There's 3 types of patients that have a shunt in. One type of patient has a shunt in that's not working. It's in their body, or they had a shunt in the past, but it's very clearly not working. Like it's broken, or it's migrated out, or something like that. And that's like a patient that never had a shunt to begin with. They were just like a regular IIH patient. So just disregard the fact there's a shunt there, if that's the case. One type of patient has a functioning shunt, where it is working really well, and their pressures are much lower than they were before. In that patient, because of the effect of removing CSF on the stenosis, you're reducing the ICP, you're taking the pressure off the vein. Those patients are almost never candidates for stents unless their shunt fails. So it's just, I've done a fair number, not that many, but enough venograms on people just to see, because they're miserable, and none of them were ever candidates for stents if the shunt is working really well. Meaning that their pressures they were in the 30s or 40s before. Now their pressures are in like the low 20s, let's say. There is a subset of people that are in the middle where they have a shunt that is in and it's working. You do a nuclear medicine study, like a shuntogram, stick a needle, inject radiotracer. It's traveling through the shunt. That shunt is draining some fluid. But their pressures are still, even with the shunt in that's partially working, are still in the high 20s or low 30s. And I've stented, I think, 4 or 5 people that have had persistent stenosis even in the presence of a functioning shunt. Their outcomes have not been like super, because their gradient is never more than like 6 or 8 or 10 points. It's not some giant gradient. There is some benefit to it. I think you can make an argument that if you can reduce the pressure with stenting, it probably actually make the shunt function better and will help lower their pressure. But many of those people are sort of in the difficult to treat patient category. There's this whole subset of people that just in general with IIH that will fail treatment. It's a regular occurrence that you stent somebody or shunt them, and 6 months later they come back and they say, I don't feel well. My headaches are back. The tinnitus is back. And many of these patients, their pressures are quite a bit lower than what they were beforehand, before they got a shunt or before you stented them. And you're like, I don't understand. Your pressure was 35 before, now it's 23. You should feel better. And they say, well, I don't. And their pressure is 23, and then you drain them down to 10, and they're like, oh, I felt great for 6 hours. It's like a brand new person for 6 hours again. This is a recurring theme with this condition. With medical treatment, with surgical treatment, like, patients will develop recurrence of symptoms. It is expected to happen. Having a honest discussion with patients ahead of time so that they understand there's a high chance that they do have headaches that come back in the future. They may not be as bad, but likely they're going to have nagging headaches that go on in the future, I think is really important. So they have that expectation ahead of time. But then developing your own protocol for what to do with those people. In my practice, I tend to do spinal taps and see where their pressure is. And you can use the spinal tap as a marker for whether you think there is some sort of stenosis that's recurred or developed. Mathematically, it's not perfect, and there's probably issues with doing this, but if you know what their opening pressure was the first time, and you know what their venous pressure was the first time, and you know what their gradient was, and you knew what their central venous pressure or their pressures caudal the stenosis were the first time, if you stent them and that all got better, but then they're come back with symptoms, and you do a spinal tap and you know what their opening pressure is now, mathematically you can say, well, there's probably 10 points of pressure that's unexplained, and there might be a reasonable stenosis there, and you can get a CTV and look and can reassess for whether you should do a venogram and see whether there's some sort of new stenosis that's developed. It's about 10% of my patients, I think I've stented a second time, somewhere around 1 in 10 to 1 in 9. It's not a huge number, but it's enough that and the yield of a second stent oftentimes isn't as high as the first one. But with that being said, there's people I've restented that are much better afterwards. And I think it's because sometime after that first stent, they got a new stenosis that developed. And we've found that and now treated it.
Got it. Great. Well, gentlemen, I do want to be respectful of your time. It is 1:40, so thank you both for being here and taking the time to share with us your experience. I also want to commend you both on developing a subspecialty practice that treats these IIH patients. Like you said, it's a very difficult disease, and again, I just personally want to commend you both for taking the effort to become experts in this and help the rest of our field to help treat patients.
That's a whole separate discussion, is how to develop a practice that where you can still do things you like aneurysms and stroke and stuff like that, but then also take care of these patients, because it's a challenge. And I think just establishing a team that can help you with that is really, really important for your patient's well-being, but also for your own and for your team. And that's a whole separate lecture we can do.
I mean,
My friend, we can bring you back, and you're great at this, so we'll probably ask you to come back in a few months.
Yeah.
This has just popped up. So our next lecture series is Friday, March 17th at 11 a.m. It's IIH from a neuro-ophthalmologist perspective with Dr. Ronnie Bannock. She is a associate professor of ophthalmology at the Mount Sinai Icahn School of Medicine, and Dr. Boddu will be gracing us with his presence as a moderator again. So look forward to that lecture. I want to thank everybody for attending, and thank everybody for their time, and we'll see you on the 17th.